Hey guys, it's Medicosis Perfectionalis, where medicine makes perfect sense. We are continuing our playlist about pulmonology. In the previous videos, we have talked about respiratory anatomy, which was clinically oriented, and then we have talked about the histology. Today we'll talk about the pharmacology. By the way, bronchi love cyclic AMP. Why? Because it causes bronchodilation. In this video, we'll discuss some easy stuff such as beta-2 and M3 muscarinic and all of this easy stuff. And we'll talk about difficult stuff such as new drugs that you have never heard of. With that being said, now let's get started. There is a difference between the sympathetic and the parasympathetic nervous system. Sympathetic is fight, flight, fright. So if you are running for your life from a tiger, do you want to breathe? Yeah, please dilate my bronchi so that I can get more air in. Who does that? The sympathetic nervous system. How? Beta-2 adrenergic receptors. Please remember that beta-1 is in the heart and beta-2 is in the bronchi, because you have only one heart but two bronchi. Alright, parasympathetic nervous system. Let's say that you went to McDonald's and ordered 19 cheeseburgers, and after eating all of them in one meal, you felt so tired and couldn't breathe, so you lay on your lazy butt on your couch and then started digesting the stuff. Parasympathetic is called rest and digest, because now you need all of the blood not to go to the lungs, but to go to your GI tract so that you can digest this 19 meal cheeseburgers. And then when you get a heart attack at 42 years old, you blame the big corporations. Look, like McDonald's is a business. If you order 19 burgers, they're gonna give you 19 burgers. By the way, what's the name of this defense mechanism? It's called rationalization, or you can consider it projection. Acetylcholine receptors, they're nicotinic or muscarinic. Nicotinic are ligand-gated sodium potassium. We have NN in the autonomic ganglia, NM in the neuromuscular junction. Then we have the muscarinic. They are M1 through 5. They are G protein coupled, as we'll see later. Heart, smooth muscles, including your bronchi, bronchoconstriction, brain, exocrine glands, etc., etc., etc. How do these receptors work? Let's talk about the M3 muscarinic receptor, part of the parasympathetic rest and digest, which will lead to bronchoconstriction because we don't need like blood in the lung right now. We don't need bronchodilation right now. It's GQ coupled. If it's GQ, it's gonna use phospholipase C and end up in calcium. So GQ, phospholipase C, calcium. And it does that through lipid, PIP, then IP3, because 3 is the third number and C is the third letter. It's called mnemonic. And then protein kinase C and calcium contraction, calcium coagulation. So you'll have contraction of smooth muscles. Since your bronchi have smooth muscles, you'll end up with bronchoconstriction. Do you think this is good for asthma patients? No. That's why one of the treatment options for asthma patients are anti-muscarinic, also known as muscarinic receptor antagonists. Now let's talk about beta-2, part of the sympathetic nervous system, fight, fright, flight. GS coupled, S for stimulation. Stimulate adenyl cyclase, converting ATP into cyclic AMP. Remember, cyclic AMP is loved by your bronchi. Cyclic AMP, protein kinase A. It's called cyclic AMP, so it has protein kinase A. And then can increase calcium in the heart, we don't care. Inhibit the myosin light chain kinase. Myosin light chain kinase in smooth muscles is responsible for contraction. When you inhibit it, you're causing bronchodilation. That's why your bronchi and bronchioles love the cyclic AMP. So please don't forget, protein kinase A is related to the cyclic AMP, and protein kinase C is related to the phospholipase C. Methacholine sounds exactly like acetylcholine. Do you think it's sympathetic or parasympathetic? It's parasympathetic, stimulates the muscarinic. Which one? M3, because your bronchi, they have M3 receptor. Alright, and when you use this methacholine, it's going to lead to bronchoconstriction. We use this to diagnose asthma, called a challenge test, a provocation test. You give the patient methacholine. If they constricted their bronchioles and starting having those asthma symptoms, which is horrible, you have your diagnosis. Muscarinic antagonists such as ipratropium, tiotropium, they antagonize those M3 receptor, no bronchoconstriction, i.e. bronchodilation. These drugs are used for bronchial asthma. Beta-2 agonists. Since beta-2 is sympathetic and they dilate our bronchi, we can give agonists to asthma patients to help them dilate their chest. And we have two types of beta-2 agonists, short-acting beta agonists and long-acting beta agonists. Albuterol is a short one, used for rescue treatment for acute exacerbation. If you have acute exacerbation, this is short-acting. It's gonna work really fast and it's gonna improve the symptoms. Long-acting beta agonists such as formoterol. It's kind of long, like formoterol. That's how I remember they are long-acting. For long-term control of asthma patients. Please never forget this. Never, 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 ever give long-acting beta agonist alone. Stupid. I'll kick you in the butt, metaphorically speaking. Always combine them with other stuff such as inhaled corticosteroids. Long-acting beta agonists never given alone. Here is a fun thing. Some patients have exercise-induced asthma. This is not the atopy, this is not the allergy, it's just exercise-induced. Treatment, give them short-acting beta agonists before the exercise. So I have like a marathon running at 3 p.m. Okay, at 2:30, please take the short-acting beta agonist, and then when you run at 3 p.m., hopefully you're gonna be fine. It doesn't have to be a marathon. I meant like a sprint, because a marathon maybe it's like too much and then they are not gonna last for the entire marathon. Forget it. Anticholinesterase poisoning, parathione, organophosphate poisoning, irreversibly inhibit the acetylcholine esterase, which destroys the acetylcholine. Acetylcholine now is left non-destroyed or uninhibited, leading to bronchoconstriction. Not only bronchoconstriction, but all of this bad stuff. Diarrhea, urination, meiosis, bronchospasm, bradycardia, emesis, lacrimation, sweating, salivation, and the mnemonic is dumbbells. What's asthma? I need just one sentence. Bronchial hyperreactivity. That's the definition of asthma. 2 words. Narrowing in the airway and increased mucus secretion. We have 2 types. Extrinsic asthma, which is the atopy, which is the type 1 hypersensitivity, also known as immediate type hypersensitivity, and intrinsic asthma, which had nothing to do with immunology or allergy whatsoever. Trigger here is hypersensitivity to environmental agents, pollens, dust, etc. Here, had nothing to do with that allergy. So it's cold weather, because cold weather is an irritant to your bronchi. It's not atopy, but it's just an irritant. Aspirin, because aspirin inhibits the cyclooxygenase, and now all of the arachidonic acid is going to become this leukotriene, and leukotrienes are horrible for asthma patients. Exercise-induced asthma, stress, upper respiratory tract infection. All of these are non-allergic or non-immunogenic. IgE-mediated extrinsic asthma, of course, yes, it's an atopy. It's a type 1 hypersensitivity. The IgE, the mast cell, the histamine, the degranulation, the sensitization, all of this fun stuff. Here, nope. And this extrinsic asthma begins in childhood. Pathophysiology of extrinsic asthma, the one that's related to atopy, to hypersensitivity, to allergy. So we have an antigen, could be dust or pollen, whatever. It goes into your lung. The mast cell becomes sensitized. And then when this antigen comes again, the mast cell will be degranulated. Boom! They rupture, they burst, secreting PGD2, which is prostaglandin D2, leukotriene C4 and D4, and histamine. Now we will discuss asthma later, and we'll discuss like detailed diagnosis later, but in brief, history of atopy, clinical diagnosis, methacholine challenge test, provocation test, they constrict those bronchioles. Reversal of symptoms following administration of beta-2 agonists. So, patients having an asthma attack, give them beta-2 agonists. If they improved, you have your diagnosis. But it has to be like objective. PFTs, you can have obstructive pattern. That's a theoretical thing, because the patient is having an asthma attack right now. Oh wait, let's send you to the respiratory lab to get some PFTs. Shut up. Drugs that are used to treat asthma are 7 categories. Corticosteroids, beta-2 agonists, muscarinic antagonists, mast cell stabilizer, methylxanthine, and anti-leukotrienes, monoclonal antibodies against IgG. These 7 can be grouped into 3 categories. The bronchodilators, the anti-inflammatories, and the leukotriene inhibitors. And then the leukotriene inhibitors are going to be divided into LOX inhibitors such as xylulton, and you'll have the leukotriene receptor antagonists such as the montelukast and zephyrlocast and anything that ends in lucast. Membrane phospholipid, phospholipase A2, arachidonic acid. Cyclooxygenase, you have those prostaglandins. Lipooxygenase, you have the leukotrienes. Alright, what does aspirin and all of the non-steroidals do? They block the cyclooxygenase, and then when you block the cyclooxygenase, all of the arachidonic acid is going to be shifted to the leukotriene pathway. Leukotrienes are horrible for asthma patients. That's why aspirin induces asthma, and it's bad for asthma patients. Also other non-steroidals, same freaking concept. Now we understand why steroids are the most potent anti-inflammatory drug in the history of mankind. Why? They block both the cyclooxygenase and the lipooxygenase. How about the drug xylulton? Xylulton inhibits the cyclooxygenase here. So xylulton is good for asthma patients because now we have no leukotrienes. There is another group of drugs that works at the receptor. So even if those leukotrienes are formed, now they're gonna bind to the receptor, but there are classes of medication or a class of medication that inhibits this called leukotriene receptor antagonists, such as the famous montelukast. Xylulton is here, montelukast is down here. Again, xylulton, montelukast. Can we use inhaled corticosteroids for asthma patients? Yes, because they inhibit both pathways, including the lipooxygenase pathway. So yeah, you can give steroids to asthma patients. If it's mild to moderate, you can give inhaled. If it's really severe, you can give systemic, but for not so long because systemic steroids have lots of side effects. They will make you fat, they can damage your bone, etc., etc., etc. So let's discuss the 7 classes of medication used in asthma patients. First, corticosteroids, inhaled or systemic. Inhaled, fluticasone, budesonide, memetazone, who named these things, and beclomethasone for moderate to severe asthma. And we have the systemic, which is oral, prednisone, or IV, prednisolone, so it has the L. So the one that has the L, you give it intravenous because your vein is so long it looks like an L. Next, we have the beta-2 agonist, not antagonist, but agonist, short-acting and long-acting. What's the most important fact here? Long-acting is never used alone as monotherapy. Always combine it with inhaled corticosteroids, such as formoterol. So formoterol is the long-acting beta-agonist, and budesonide is the inhaled corticosteroids from here. All of you have heard of the famous class of medication called beta blockers. Remember, they are good for your heart. They decrease the heart rate and the blood pressure, etc. What if you're using long-acting beta agonist, not antagonist, but agonist? You'll have low threshold for tremors and palpitations. Makes perfect sense because they stimulate the beta-1 receptors in your heart. Muscarinic receptor antagonist. They are anti-parasympathetic. Short-acting, such as ipratropium. Long-acting, such as tiotropium. Tio has a long tail, so it's long-acting. Alright. Drug of choice if the patient was induced by a beta blocker. So, if this asthma caused by a beta blocker, because one of the side effects of beta blockers is asthma, especially if they are non-selective beta blockers, if this is the cause of asthma, M3 antagonist is the drug of choice. Mast cell stabilizers, such as cromolyn, and there's also nidoquermin, ketotifen, etc. They are histamine release inhibitors because they stabilize the mast cell. It's not going to degranulate. They're available over the counter for other stuff such as seasonal allergy. Methylxanthine, such as theophylline. Theophylline can treat apnea associated with prematurity. It inhibits phosphodiesterase, no breakdown of cyclic AMP, because remember, you have first ATP. Adenylate cyclase, you have cyclic AMP. Phosphodiesterase, you have degradation products. Pieces of trash. So phosphodiesterase is here. This amazing theophylline inhibits this phosphodiesterase. It inhibits the degradation of cyclic AMP. It preserves the cyclic AMP. And cyclic AMP is the hero for the bronchioles. They love it because it dilates the bronchiole and makes you breathe in beautifully. Theophylline is an adenosine antagonist. What does adenosine do? Bronchoconstriction. If you antagonize the adenosine, you're gonna cause bronchodilation or at the very least prevent bronchoconstriction. Side effects of theophylline: narrow therapeutic end, arrhythmia, big deal, CNS excitation. I wasn't joking, arrhythmia is really a big deal. Here is a table that will make you feel good about yourself. Adenosine and theophylline, they hate each other. Theophylline is anti-adenosine. Adenosine causes bronchoconstriction. Therefore, it causes asthma. Theophylline is the opposite, prevents bronchoconstriction, therefore treats asthma. Adenosine treats cardiac arrhythmia, especially SVT, supraventricular tachycardia. It's a class 5 antiarrhythmic. Some people recognize it as class 5. The opposite is theophylline. It causes cardiac arrhythmia. So this one causes bronchoconstriction. This one treats bronchoconstriction. Adenosine treats arrhythmia. Theophylline causes arrhythmia. Please don't give adenosine with theophylline. It's known as stupid. Theophylline is very similar to caffeine or aminophylline, so theophylline, aminophylline, and caffeine, don't combine any of these with adenosine. If you're taking adenosine, don't drink coffee. If you really love coffee, drink decaf coffee. Here's a nice mnemonic for you. Muscarinic antagonists as a class of medication have trope in their name. Atropine, ipratropium, tiotropium. Anti-leukotrienes, we have two, the LOX inhibitors and leukotriene receptor antagonists. Xylutine can increase your risk of infection. Why? Because one of the leukotrienes was leukotriene B4, and leukotriene B4 was responsible for chemotaxis. When you inhibit chemotaxis, you're gonna get infections because you have no military to fight the infection. Leukotriene receptor antagonist montelukast and zafirlukast. They can cause eosinophilic granulomatosis with polyangiitis. The old name is Church-Strauss syndrome. Monoclonal antibodies against IgE. This is new. Any drug that ends in MAB is going to be very expensive. Remember another drug that ends in MAB? Rituximab for lymphoma, for rheumatoid arthritis. It's a chemotherapy. There is another one, denosumab for the bone. And we have talked about this in my video called Rank and the Rank ligand. Here is a very important thing. Do not use this omalizumab for intrinsic asthma because intrinsic asthma has nothing to do with allergy or IgE. Okay, so it's pointless. Here are the drugs used in asthma management. Please memorize them. Here is the pathogenesis of asthma. Here is how to treat it or prevent it. So antigen, avoid the antigen. Avoid the pollen or the dust. Mast cell sensitization, use a mast cell stabilizer, anti-IgE, etc. And of course steroids, it's anti-everything, including anti-allergy. Early response, you have the bronchoconstriction, use a bronchodilator. Late, we have inflammation, use an anti-inflammatory. I know you're struggling with Legionella, Mycoplasma, Pseudomonas, rhinovirus, Moraxilla catarrhalis, etc. Please go to Picmonic. They have medical mnemonics in pictures and animations and videos. They are awesome. The link is in the description below. How to manage COPD. Do not use leukotriene modifiers. Why? It's ineffective because the mechanism or the pathogenesis of COPD does not involve leukotriene, so it's pointless. There is a new oral drug called roflumilast used for COPD, for advanced COPD, specifically for the bronchitis, not the emphysema. That doesn't mean if the patient has emphysema, we shouldn't give them. You can, but it targets bronchitis more than emphysema. It's a phosphodiesterase 4 inhibitor, so cyclic AMP is gonna rise because no one is degrading it, and your bronchi love the cyclic AMP. COPD with frequent exacerbation can benefit from azithromycin, which is a macrolide antibiotics. Side effects of azithromycin: hair loss and resistant bacteria. If the patient has COPD, please vaccinate against a bacteria called pneumococcal and against a virus, that's the influenza virus, aka the flu shot. Here is the mechanism of action of roflumilast, the new anti-COPD drug. It's a phosphodiesterase 4 inhibitor. It's gonna prevent the degradation of cyclic AMP. Cyclic AMP is gonna increase, and your bronchi love cyclic AMP because it leads to bronchodilation, so you can breathe in. There is a new drug for cystic fibrosis called Ivica, introduced in 2012. It's not that new, but if your pharmacology professor is an old dinosaur who has never opened a textbook since man walked on moon, you have never heard of this drug. Treatment of cystic fibrosis. By the way, why do we call it cystic fibrosis? Because we have cysts in the lung. Not true. Because we have fibrosis in the lung. Not true. The cysts and the fibrosis are in the pancreas, not the lung. Treatment: oral pancreatic enzymes because the pancreas is screwed, antibiotics because infection, recombinant human DNase, inhaled hypertonic saline because the problem in cystic fibrosis is that the secretions are so thick inside your airways. If you give an inhaled, so you introduce this medication inside the airway, it's hypertonic, so it has lots of sodium. What does sodium do? It pulls water from the outside, hashtag osmosis. Water is gonna go inside, making these secretions kind of smooth and not that sticky and thick, so the patient can live and breathe. CFTR potentiator, it's called the Ivica, because the problem in cystic fibrosis is in the CFTR. When you potentiate the CFTR, such as Ivica, and the combination Lumacaftor, Ivica, you're improving the symptoms of cystic fibrosis. A new drug for COPD is called roflumilast. A new drug for cystic fibrosis is called Ivica, a CFTR potentiator. Thank you so much for watching. Please subscribe and join the tribe. Hit the bell to get notified. Follow me on Facebook. I have more than 100 cases there. You can get all of my notes and all of my cases and all of my tables and all of my audio notes. Patreon.com/medicosis. Thank you so much for watching. As always, be safe, stay happy, and study hard. This is Medicosis Perfect Snails, where medicine makes perfect sense. Even pharmacology does.